Yeah, so from where we are coming from, what becomes so clear and what becomes so important that even as we practice prescribing these drugs, we should have full understanding of the backing of the law in our context um, as midwives. You are welcome. We cannot practice again fully in a more autonomous manner if we are unable to understand what our laws in our various countries speak to the issue of a midwife prescribing. So we are saying the key concepts that we want to pick from this slide. Number one has to do with the law itself. We need to know the rules and regulations that our various governments have established. What is contained in the act in your country pertaining to this issue? We should also know what the Medicine Act in our country speak to when we are discussing the issue of prescription. Secondly, even as we are doing this, we are guided by moral principles and values that would speak to our characters, that would speak to us doing right, that would speak and help us identify that, yes, I've done something wrong. So as midwives, we have an opportunity to learn of what is obtaining in our countries with regards to the scope of practice when it comes to pharmacology. Now, I know that despite us being domiciled in different countries, there should be one national legislation which speaks ultimately to this issue. It could be the Nursing Act, it could be the council regulations, it could be the Farmers Poisons Act in your various countries. And one thing that is critical is, I think, for us to understand. For example, in Zambia, we have a list. It is called the essential list, which a midwife and a nurse can prescribe from. It contains some antibiotics. It also contains other drugs that are so specific to midwifery practice. So that informs the practice itself. You cannot prescribe drugs that are beyond. And because of this, one thing that is also noticed that nurses, midwives are permitted, are allowed to open even health shops, and they can stock some of these drugs and sell as long as they meet the criteria and the standards. Now, our focus, even as we are discussing, is on the southern part of Africa and other countries in Africa. And this prescribing authority is usually regulated by the nursing and midwifery councils, and in addition, by the acts which Parliament could have passed. And apart from this, we are also permitted to ensure that we supply, we dispense in the context of midwifery. When we come to administration, we must adhere. Remember last time we were discussing 5 rights, but 2 more have been added to make it 7 rights. So these are things that we need to adhere to. Apart from this, colleagues, the issues of accountability and negligence. Accountability and negligence. Surely, in this day and era, someone would not give magnesium sulfate to this mother who is convulsing. Meanwhile, the drug is available, and when they are questioned, their only response could be, I did not know how to administer. And this could have been the cause of this maternal death. It is unacceptable, and these are things that should never be entertained. I know that maybe just asking Julia or Seraphine in your countries, do you conduct MPDSR meetings? And what are some of the issues that could be coming frequently every time you're logging into these MPDSR meetings? Any responses?
On my side, I used to attend, but we had a child. I'm working at the college. I'm teaching at the college. So
Okay.
our hospital was used to, we were part of the committee. So
Mm,
they used to invite us into those reviews.
mm,
But because they don't want to be, if there is negligence and to tell them that this was negligence, they
mm.
don't like that. So nowadays they are no longer inviting us. That is, I'm missing a lot.
Yeah, so that becomes a problem already. But what could have been some of the issues, I think, from the time that we're attending that were coming repetitively as the cause of maternal deaths?
Most of the time would be that they delay to identify problems so that they can intervene on time. Sometimes you'll find that there is a not there is a lack of good working relationship between the doctors and the midwives. There are lots of fight. The midwife can't call the doctor on time where there is a need for the doctor to intervene. It was a lot of negligence, most of causes of maternal deaths.
What's the maternal mortality rate in your country?
It's very high. It's very high.
What is high?
I can't say because I'm not yet I'm not sure of the recent statistics, but it's high. We even tried some interventions of making the learning hubs, simulation centers in the hospitals, so that these midwives and doctors they can practice more often. Uh, a doctor when is supposed to be rotated to maternity should simulation center to remind him or herself about certain skills. So after that, because it's about a year post that intervention of simulation centers, I was told that the statistics of maternal deaths and neonatal deaths have reduced. I'm not quite sure of numbers, Doc. Thank you.
Oh, great. So I think for Zambia, we are at 187. This year, we are at 187 per 100,000 live bits, which it's a huge, huge reduction. So yeah, I think I've heard from your end. Seraphine, any contributions, any experiences? Okay, seems probably maybe the network issues. Yes, so one thing that comes out strongly is lack of the skill. And I think even from your submission, clearly, a skill is one thing that is missing. I think for Zambia, we have organizations such as SolidarMed that have come in and they are helping a lot. We have simulations, mouth facilities in terms of skills lab dotted in hospitals, some hospitals across the country. So accountability and negligence with pertaining to these prescriptions become a real issue. Very, very, very real issue. Now, midwives are personally accountable for our professional acts and omissions, even when we are working under an obstetrician overall care. And one thing that is common, and by definition, we know that a midwife is an autonomous, this word never misses in the definition of a midwife, autonomous practitioner. But when this autonomous practitioner cannot account for things that they have done, it becomes an issue. Medication-related negligence, it's there. And by the way, negligence, it's just the inability of this midwife to exercise the care that someone who is reasonable would have exercised. And by the way, if someone is taken to task, there are issues that would be picked out, issues to speak to the duty. Whose duty was this? Who was in charge of this woman? Who was supposed to have administered this drug? It is a midwife. Breach of duty. A midwife failing to meet the standard of care, giving a wrong drug, not even knowing how to calculate this drug, not knowing even how to dilute this drug. Possession. They breach directly, causing harm to this mother. So we really need to be accountable. We never need to be negligent in the manner we executing our duties. Now, common errors in medication would include prescribing errors. Sometimes could be administration errors. Sometimes it could be monitoring errors. Okay? Prescribing errors. For example, someone prescribing outside the scope. Okay? Wrong dose, the wrong route, contraindications are well ignored. When it comes to administration errors, failing to check the 7 rights, the right drug, the right dose, the right route, the right time, the right patient, the right documentation, the right reason. And we have added this one, right to refuse, which is now on the mother. Sometimes they would refuse because you have not given them adequate information. These are things that should never be entertained. Monitoring errors, failing to monitor for and act on adverse drug reaction. This is so common. Adverse drug reactions. Pharmacovigilance becomes a principle. It's a principle that we need to adhere to. But when this principle is not taken seriously, these things would arise. Now, what are ethical principles in pharmacology? Of course, we looked at those principles which were away from what we are discussing when we are discussing the legal and ethical implications. So the core ethical principles would include number one, autonomy, self-determination, respecting the woman's right to make informed choices, including informed consent or refusal of pharmacological interventions. For example, pain relief, okay, induction. You are forcing this mother, no, I just have to inject you. Meanwhile, there are alternatives. That's why midwifery mode of care would view labor as a normal process, okay, as a normal process, a process that is devoid of any other adverse things. So autonomy. The second one is beneficence, doing good, acting in the best interest of the woman and the fetus or neonate. For example, administering a life-saving drug. Okay. This becomes so important. Thirdly, non-maleficence. Do no harm. Even as we are handling these drugs, we should minimize risk and cautiously refrain from doing harm. And how do we achieve this? By carefully calculating high alert medications. High alert medication would include magnesium sulfate. Okay? The other one is on justice, fairness. Fair allocation of scarce health resources. Important. But we would discover some of us may have these opportunities of saving at in our country. The way it is structured, we have districts, provinces, and so on. So others could be counties and so on, municipalities and so on. Some could have these opportunities to work at that level, but you are not fair. Allocation of these resources is not leveled. And at the end of the day, what are you doing? You are denying this mother and the newborn baby to the critical medication that they would need. Velocity, being honest with the woman and colleagues, especially regarding potential risk of actual errors. Be truthful. I erred, I did this. So these are principles that would help us operate with so much with so much care. We have ethical dilemmas, okay? We have ethical dilemmas, even in pharmacology, okay? And how do we navigate these dilemmas? The first dilemma is drug stockouts, okay? And what is at conflict in terms of the principles, justice. And this is fair allocation versus beneficence, best possible care. And what should be our response? We need to advocate for better supply, okay? Better supply, applying strict triage guidelines, use of non-pharmacological interventions. For example, the rubbing of the back to relieve pain in labor. And once you are doing that, you are reserving on this, you are trying to resolve this dilemma of drug stockouts. Instead of you could have used that such and so drugs, they are reserved because this midwife has mounted advocacy, okay, and has used alternatives, initiatives in ensuring that there is no pain. Secondly, maternal-fetal conflict. And this, the ethical conflict under this is maternal autonomy. This woman is refusing essential drug, okay? And for you, you think this is a drug that will help this mother survive. But on the other end, this mother refuses. And by the way, because they have their own autonomy, they have this right to decide. They have this right to accept or refuse care. Sometimes this could be related to our cultures. Okay. So now, what could be your response? Number one, at times it is important that as a midwife, you need to respond by effective IEC, information, education, communication. Very critical. Sometimes we do not explain. I was sharing with you last time. Just because you have delivered this mother, it does not give you the right to just go and inject the oxytocin. No, for me, on my end, it's the active management or third stage of labor. But have you communicated to this mother of the need of this injection? If not, these issues will arise. Protocol limitations. The ethical conflict is that we, at all times, have a duty to follow protocols. And again, some of these protocols may not just give us an opportunity to exercise our professional judgment. Sometimes these protocols are inadequate. I would give you an example away from what we are discussing. I am working in this labor ward at night. Next to this labor ward, there is a cholera center because we have this cholera that is so much in the country. Then this woman who is in the cholera center goes into labor. They go into labor, and we understand, we have learned about cholera. There is effortless diarrhea, there is projectile vomiting, and these nurses who are working, they have no option but to rush to labor ward. And they call on me, no, we have a situation. There is this woman laboring. And what I discovered is that the Vibrio cholerae will produce the endotoxins, which I believe so, which will result in uterine contractions even prematurely. And now we understand, we have worked in labor ward. Whenever this woman pushes, fecal matter comes out. This fecal matter is not just any other fecal matter, it is contaminated fecal matter. So, which protocol would speak to that practice? None. Search through your infection prevention protocols, you will never find this written clearly. When this woman goes into labor, they have cholera, you need to do A, B, C, D. None. I go there. I tell this assistant, can you dilute chlorine? Not too much. Let it be diluted to a level that the baby cannot be affected. We do the dilution. We put this chlorine in a sprayer. Okay. Whenever she pushes, fecal matter comes out. What do? We clean the perineum. And now all of us, we are gloved. Gynecological gloves. There is nothing like you need to put on surgical gloves that are just going to the wrist, high level up to there. When the baby is born, we flush the baby, bath the baby immediately. So these are things that are not written. But at the end of the day, your focus, you really want to help this baby not to have the cholera. And one thing that I've not done midwifery response is documentation. This deviation from the protocol that has already been established for infection prevention. So there's justification already. We need to ensure that this baby is safe. So these are things that would be getting into. Are we following? Are we together up to this end?
Yes, we are together.
Great, thank you. So the other thing that is so important is for us to know our institution policies. We need to familiarize ourselves with what the institution speaks to. Then, yeah, apart from this, legal and ethical requirements speaks to us doing the correct thing. Last time I emphasized the right here is not the human right, but it's a correct, C-O-double. This C-O-double-R-E-C-T. So the 7 rights for medication administration, last time we said 5, we have added up 2. So we need at all times, there's a hand that has been written. Please, you can unmute yourself.
Thank you. Good evening, everyone. I have a question on the previous slide
Yes, please.
about the midwife managing a different ethical dilemma, especially concerning the autonomy.
Yes.
I'm asking about these things of the professional protection. Especially when the mother refuses the medication or refuses a certain procedure, and then the midwife have explained everything and documented everything, and even the midwives involve the senior care providers to help in the management of the case. Then at the end, when the outcome is good, it is always good, and you are all appreciated.
As always.
But when the outcome is poor, I feel that there is no protection. There is no professional protection concerning that.
Yes, please.
Yeah. That's the major concern actually that happened. Not only for the autonomy, but for all other ethical dilemma, like the stockouts you have just mentioned.
Yes.
You have given an example about the use of non-pharmacological management for the labor pain, but there are other medication which can miss from the institution and you don't have any substitution. And when the mother have a problem, I feel that always the midwife has to answer. They are answerable to the problems than other healthcare providers. Yeah.
So yeah, thank you so much for that. Maybe before I come in, any responses from colleagues here? A very good submission, Seraphine. Very good submission. And this is a situation everywhere. It is not just in your country, but it is everywhere. I would give you a very good example. Recently, as Zambia, we had seen a drop in enrollments in midwifery colleges. No one wanted to train as a midwife, especially the in-service. Why? For things that you have cited. When this mother dies, everyone will come down on this poor midwife. And at the end of the day, no one cares. They are left with this guiltness And at the end of the day, the ripple effect of the negative attitude that was created led to a drop in the number of midwives getting trained. So for me, one thing that we have not done very well is advocacy. We have not advocated nicely. And the other thing is that our midwifery associations, they're extremely weak. They're extremely weak. These are individuals who may not just speak out. The reason why they exist is for things like these. They need to intervene, they need to speak on behalf of this poor midwife, but they're unable to. So in such a situation, documentation becomes so important, as you have indicated. You have documented. If the outcome is good, everyone is praising you. You receive cakes and so on. When things go down, everyone is Z. But for me, one thing that we have introduced as a nation is the non-castigating of those midwives who could have done what they could, but things have not just worked out. And therefore, one thing that we are strongly advocating for is the issue of discussing maternal near misses. Women who could have died due to severe morbidity, but they have survived. So instead of us discussing on negative things, why can't we start appreciating the positive things that are happening? And this picture may change slowly if we go through such a route. But at the end of it all, personal individual advocacy becomes critical. Speaking on yourself becomes critical. And the thing that I've also noticed that as midwives, we are not assertive. We are individuals at times who are easily intimidated, individuals who cannot stand on their own and speak. And at the end of it all, everyone would want to trample, even on things that we could have done rightly. So it's a difficult situation, but I think we can do what we can. That is why, for us, we are trying to push that the midwifery model of care is institutionalized. Midwives can practice on their own. I know I read of studies done in South Africa, studies that are done in Rwanda, in Uganda, where we are seeing midwives practicing independently and so on. So despite us having these positive things coming in, but we can do more by promoting training midwives in individual advocacy. And this is a team that can do that. Become a change agent. Why should everyone fall on this poor midwife? And at the end of the day, they are meant to write a lot of reports. Others have subjected even to the courts of law. You are not practicing out of your mandate. You are practicing within your mandate, and anything can happen. So we can speak about this thing. Maybe there are any comments from anyone.
Thank you very much. You have said it all, and I think what you finished on about the capacity building, it's very essential for midwives to be able to speak for themselves and for ourselves. Let me include myself. Yeah,
Definitely.
the capacity building is very essential. Thank you very much. If there is not anyone commenting, so I understood.
Oh, great. Thank you. Maybe let's just quickly go through maybe there's a comment again. Okay. So the 7 rights of medication administration, of course, this medication that we are administering should be to the right patient, and this should be the right drug. The dosage should be correct. The route, the time, documentation. And apart from that one, for the right reason, the judgment that has been given. Now, Out of these rights, one right that is so important is documentation. It's a key. This is our weakness. This is our weakness. Why should we let obstetrician write those books, and ourselves we are writing spanly, not much, with a bit of fear? And sometimes you are working, you have called on this specialist to come, they are not coming. Right, on so time I called this one, and name them, Dr. so called. Or if there is a midwife specialized more than you, right, on this time I called, did not come. But when it comes to medication, it becomes important. And this documentation should be clearly written, signed nicely, so that if, for example, there are any adverse reactions, we know what to do next. Accurate and timely documentation is the strongest legal defense. We need to know that immediately this patient walks into our facilities, any document we start producing becomes a legal document that would be used in the court of law. And if this legal document is not written appropriately, it is not written in a clear manner, it becomes an issue. How then are we going to be defended? Now, this brings us to professional responsibility and advocacy. This is one area we are not doing well. Advocating. This advocacy in pharmacology speaks to us talking strongly on these drug stockouts. Why should we have a facility running without these essential drugs? Why should we have this facility running without oxytocics? Why should we have this facility running without anticonvulsants? What would happen in a situation, this woman, for example, has delivered, placenta is out, they are not given oxytocin, and they start bleeding? Who would be responsible? We are losing women, we are losing our babies because of this negligence. And for us at this level, it is a level of competence. It's a level of us understanding things deeper. And there's no way we can stand and practice without knowing how to advocate. I'm not sure in your training if there are issues pertaining to advocates. It's an important thing that we need to subject it to. Systems advocates. Advocate within your institution for one, clear, updated national and local drug formularies. I know even in our countries, every year, they are producing these guidelines, the formularies. We have WHO standardized protocols, which should be stuck in our labor wards. Very important. And the way we actually even store our drugs, it's something that no one can not even speak of. Drugs are stored everywhere. There are no lockable cupboards. And at the end of the day, anyone can take these drugs to their facilities if they are running one. Culture of error reporting without blame should be encouraged. Non-punitive culture. If someone has done something wrong, they have administered the wrong drug, it's not that they did that knowingly at times. It is because they are not subjected, or they don't know. So why can't you go with the heart of capacity building? That's what is important. But every time, if there are managers amongst us, you are ever castigating these junior officers. Meanwhile, we don't have time to sit with them to teach them. Especially these who could have graduated from school. Everyone wants to make them put to shame. But this is at the expense of a woman. Induction, we don't do. Okay? Someone will just come, start working. I know Judah comes from a college. This is a new graduate. They just go straight to class to teach. At the end of the day, students are protesting. Okay? Maybe Seraphine is coming from a facility. This student just comes after graduating without even experience. They are late. You'll be working night duty alone. They encounter a problem, it becomes an issue. Punitive culture. This is something that we need to run away from. Cultural competence. Recognize how culture beliefs impact acceptance of pharmacological care. We're just discussing the other day on the issue of traditional oxytocin. These are things that are passed from generation to the next. Even educated women, they know these things. But what is important is the bringing out the negatives in a proper manner about these things. Their use will not die now. And by the way, for me, these are research opportunities. Research about these things. Why is it that they are still clinging on to them? If they were not working, why should they still be using these herbs? These are potential studies that we need to do. If it means cross-country, we do it and learn. So cultural competence. We need to recognize some of these things that are surrounding our drug administration. Now, one thing that we also need to do is to adhere strictly to the laws that are governing our countries. Okay, if you act as midwives, stipulates what you need to prescribe on, we just have to adhere to that. Apart from this, the issue of controlled substances and reliability. These controlled substances, like opioids, pethidine, these should be kept in a place that is lockable. That's why they are not over-counter a drug that could be prescribed by anyone. And for us, we become custodians, people that should guard safely, because once these have handed in wrong hands, we would see issues of drug dependence and so on. And these are things that we should avoid at all costs. Now, even as we are doing this, there are issues to do with informed consent and refusal. Okay? ICM focuses on this. So the International Confederation of Midwives stresses the partnership model, where a midwife and this woman will share relevant information for them to make an informed decision. And this becomes so important. And apart from this, despite this information or despite these opportunities, at times we decide to go on our own and do things on our own, okay, besides what these women would bring on the table. Sometimes we think they are not educated, so there is no need of consulting them. But one thing that is important is that even as we administer these drugs, we need to be in constant consultation with these women. Just explain. They are not difficult. Once they understand the reason as to why they need to receive this medication, they will cooperate and the outcome is always positive. And apart from that, of course, we have the issue of pharmacological informed consent. This cannot be documented at times, but this could be verbal. She has agreed, and at the end of the day, we achieve the greatest. Now, yes, they have the right to refuse treatment, and this is legally binding. But at the end of the day, our duty is to ensure that they understand, they receive the information and the consequences. There is a situation that occurred some time back where at one of the biggest university teaching hospitals, this woman is scheduled for a cesarean section. The way they approached her, it was so harsh. He stood fear in her and she said, "No, I cannot go to theater. It's better I die." I walked.
Sorry.
Yes, please.
I want to know if a midwife can prescribe a medication during labor when she's conducting a monitoring of labor. Is it allowed to prescribe a medication like oxytocin without consult a specialist?
Okay, great. That's a question. I've seen a hand risen. Yes, please, the response.
Yes, I want to answer to her question by stating that it will depend on the institutional or national guideline about that. Yeah. So you need to check if it is accepted or not, and then you will act accordingly.
Exactly. That's a very precise answer. Which country are you practicing from, so that we help you go around?
Rwanda.
Rwanda, definitely. I think they could be that allowance. Yeah. So drug like oxytocin, yes. Back here in Zambia, this is something that midwives prescribe and they administer without even consulting any patient. Magnesium sulfate, they will prescribe and they will administer without any consultation. So for sure, you really need to check the act in your country and just check through what is allowable or what is not allowable. Hopefully that is clear.
For us, the oxytocin for labor augmentation prescription for midwife is not allowed, unless this verbal telephonic prescription, when the doctor is not allowed and you see that the mother needs labor augmentation, and then you have to call her or him to allow you to give that, and then you have to be two nurses or midwives, and then you document, and the doctor will stamp it within 24 hours. That's how we do it. As for the oxytocin for the active management of third stage of labor, the midwife can give that without any consultation. Same for the magnesium
sulfate,
but you will need the doctor to prescribe those medication even after you give them.
Magnesium
That's
sulfate.
how it is done.
Okay.
We give it for the emergency cases, but at the end of the day, the doctor have to prescribe those medications.
Okay, so so that's good to hear. I think what we need to advocate for is the advocacy. It's under advocacy. It's at times it's the woman's life that is at stake, and at the end of the day, those procedures are very good, and I like the use of a telephone. I think that's a good practice, which at the end would save the life of this mother, despite not having this doctor around. So yes, that's great. Now just that sometimes a midwife could even be more experienced than this intern that comes through on to prescribe things that they are not so sure. So what is important is also for us to be so knowledgeable and guide. We really need to guide that this and that should not be given at this opportune time. But all in all, I think those are very good responses. So let's check what is prevailing in our countries before we do any other thing. So I think those are very important responses, Seraphine. Julia, any comment? Who is raising the hand again? Julia, yes? Seraphine?
I was about to say that it is not reasonable that a midwife who monitored the labor throughout the process, and then the midwife already know that the mother need augmentation. I cannot see why we cannot prescribe the oxytocin for labor augmentation. Why we are the one who detect that the mother needs that's augmentation. And what we need is the advocacy for them, for the government or any other regulatory body to allow us to even prescribe those medications. Yeah.
I agree
Yes,
with you.
Seraphine, I am agree with you, but we have found that our association are very poor in advocacy. So I found that for us who are doing this training, you can do more advocacy to change and avoid some resistance to change about our medication prescription among midwives.
I totally agree with the two of you. For sure, we are with these patients for a long period of time. These other cadres will just come through, pass through, and off they are gone. But at the end of the day, you are the one who is with this patient, but ultimately, you are eliminated in doing critical things. And I'm not pretty sure. There's a country, should be Mozambique, where midwives who have gone to master's level, they had started doing cesarean sections. And of course, there was an outcry because they definitely